Good morning viewers of this video of my guest lecture delivered in Allahabad Surgery Conference on 12th November 2016. 2 decades ago, hardly anybody knew about the mesh, but our efforts of running campaign educated almost 98% of hernia patients globally that mesh is a simple piece of synthetic cloth naturally associated with many foreign body complications. Our technique, Dr. Desarda's repair for inguinal hernia. We remember that it is based on the new concepts of physiology of the inguinal canal that prevent hernia formation. Pros and cons of existing groin hernia repairs vis-a-vis Desarda pure tissue repair. The main question is, do we need to change today's trends in groin hernia surgery now? My answer is yes, because now we have a new technique that is tension free, almost recurrence free, and with the lowest rate of complications. You repair hernia with continuous absorbed sutures, a thing never imagined till today. It is a very simple and physiological repair, easy to learn and follow, and can be done on outdoor basis under local anesthesia and with fast recovery. This repair is a pure tissue repair and does not need any foreign body. In fact, it removes disadvantages of both foreign body as seen in mesh and tension as seen in other pure tissue repairs. What are the accepted methods of repair today? Bassini repair is from Italy, Shouldice repair is from Canada, open or lap repairs from Germany, and of course Desarda repair from India. Bassini repair, it involves dissection and excision of the inguinal floor. This is very important first step of this operation. Tightening of the internal ring, suturing internal oblique and transversus abdominis muscles to the inguinal ligament. Recurrence rate was just 4%. This operation became popular, but re-evaluation by many other surgeons revealed very high and unacceptable recurrence rates. Shouldice repair. It also involves excision of the weak inguinal floor as the first step, excision of the cribriform fascia, cremaster muscle sling, 4-layer suturing with stainless steel wire, lower crux of the superficial ring suture to anterior ectosteeth to avoid recurrence at medial end. Genital nerve, external spermatic vessels and cremastic muscles are excised. This is commanding operation and needs training. Danger to iliopubic vein and femoral vessels. Shouldice made mess of clean Bassini repair. That is our view. Total excision of weak inguinal floor as seen in this picture is a must for this, and it is very risky and difficult. Profuse bleeding from iliopubic vein or danger to femoral vessels may take place. This is Shouldice repair. See how much complicated suturing is involved in this operation technique. It is almost throttling the tissues over there. Why tension repairs have failed? We have omitted the first important step of excising weak inguinal floor because of risk involved. We have modified operation the way it suits to us. Muscles are pulled down to suture to inguinal ligament, so they are under tension even at rest. This tension increases manifold during action. This tension increases further due to shrinkage of fibrous tissue in later life. Muscles are displaced from its original place, so it tries to go back to its original place. This results in more pain and more recurrences in these tension repairs. Liechtenstein mesh repair. Liechtenstein puts a mesh, a mechanical barrier. Nobody uses classical Liechtenstein mesh for repairs. A bi-tailed mesh with knitted borders was used by him. Now mesh is cut to suit surgeon's choice to reduce the cost. Loose or tight suturing of mesh can't be standardized. Size of the mesh also can't be standardized. Quality of mesh fabric is also not standardized. Why low quality mesh for poor and high quality mesh for rich? Mesh is a foreign body, a simple piece of synthetic cloth naturally associated with all foreign body complications. We should invent such a technique that fulfills all criteria of modern hernia surgery. It should be simple and safe to do and learned by the resident surgeons with good results. Does not use foreign body in any form. Does not use weak muscles and fascia. Early ambulation without much pain. Patient goes back to home in a day. Patient is back to his work within a week. No major complication and almost no recurrence. Today's operation techniques do not satisfy all those criteria completely. No doubt inguinal hernia repair therefore remained a problem till invention of my technique, and this is my humble contribution to solve this problem. What about mesh repair? Does it qualify as ideal model hernia repair based on those criteria? No. Question 1. Mesh is a simple piece of synthetic cloth prepared from polypropylene or polyester. Would you accept its routine use in all the cases? Ideally not. You are extremely cautious not to forget a swab in the abdomen during any surgery. Then question 2. Then how you are stitching a swab-like piece of cloth inside the body in mesh repairs, leaving the patient to his own fate? What we are doing today is right. Mesh is a foreign body is known to everyone. Millions of microabscesses are formed and dense fibrous tissue is laid down in inguinal canal is also known to everyone. That distorts anatomy, atrophies muscles, nerves, vas and vessels get engulfed and affected. There are complications like pain, infection, testicular atrophy, sinus formation, recurrence and many more. These all complications are also known to every surgeon and still mesh is routinely used in all inguinal hernia repairs. Why? Why not laparoscopic repair? All complications of mesh are present in laparoscopic repairs also. In fact, these complications carry high risk because mesh is stitched inside the abdomen, pre-peritoneal. Additional complications are internal oozing, risk of general anesthesia, nerve damage, trauma to viscera, trocar hernia, recurrence and many more. You can imagine what would happen to vas and testicular vessels due to mesh fibrosis because mesh is directly sprayed on these vessels and vas. Thus you know that mesh is not 100% safe to body for its routine use in all the cases. Lab repair carry high risk and requires extreme skills to give excellent results. Many patients' life worldwide might be getting affected by unscrupulous use of endoscopes by inadequately trained surgeons. Imagine the fate of millions of patients operated in remote places by many surgeons with low quality mesh without any standards. Pharma companies will not bother for patients, but you must bother for your patients. Surgical fraternity thrives for 100% safety and cure without complications in every surgery. Then how we have accepted mesh repairs in spite of its morbidity and complications? It's because no good pure tissue repair was available to common surgeons till today. It's because mesh repair is a simple operation, and also because of the perfect marketing at all levels and by all means by the companies. Product costing few rupees is being sold at 1000 to 5000 rupees, making huge profits. Companies will market this product by all means. Ethical or unethical? What is their marketing magic? Controlled publishing houses and publish repeatedly similar articles through various doctors claiming mesh repair is the best. Control conferences and make leading doctors to present how mesh repair is the best. Start CME in conferences and make it compulsory to attend to postgraduate students and then hammer on to their mind same thing again how mesh repair is the best. Come out with new products of mesh and again send leading doctors to various seminars to show how mesh repair is the best. Advantage of faith posed by trainee doctors and students in their teachers is exploited. Repeated presentations are made in conferences, repeated publications are made in magazines, and the song about mesh goes on and on till junior or budding surgeon's mind gets preconditioned to such an extent that they stop thinking beyond mesh for hernia repairs. Who is the loser? The deadliest loser is your own patient. Many patients operated with mesh, open or laparoscopic repair suffer from morbidity and complications. Some patients' life gets ruined. Who is responsible for this? But still companies with our help are busy in marketing their product like a soap or hair shampoo. Every time coming out with a new variant of the same synthetic cloth like mesh, then mesh and plug, then PHS, then heavyweight, then lightweight, then small pore, then large pore, etc. etc. And who is the winner? And the winner is mesh manufacturing company that silently pocket millions of dollars profit every year from all over the world. And what about doctors who are catalytic agents and with whose help companies are marketing or making huge profits get? Nothing. Our prestigious organizations have all given our platform to them and made them financially giant. But still we doctors have to bargain with them about selling stalls or getting advertisements or sponsorship. And to stop this, we need to find such a simple operation technique that even a junior resident can also do it with minimum complications and recurrences. And to achieve this, let us understand the etiology of inguinal canal, a revolution in groin hernia. We claim that old concepts that prevent inguinal hernia formation described in the textbooks are not true and perfect. They need to be reconsidered. A revolution in the concepts and technique. Misconceptions. First, posterior wall of the inguinal canal is formed by the transversalis fascia. No, it is wrong. Strength of the transversalis fascia gives protection. No, it is also wrong. Obliquity of the inguinal canal, shutter mechanism, and many other theories are described in books. These all theories are not true and perfect. Rigid anatomical wall created by mesh can give best results. No, this is also not true. Strength of transversalis fascia described in every textbook is not true. The transverse fascia do not have any strength and it cannot give any protection because it is papery thin. It is just an extension of the endo-abdominal fascia. Obliquity of the inguinal canal is not true because the spermatic cord is lying throughout its course on the transverse fascia alone. It does not pierce three muscles as stated in all the textbooks. Every individual with high arch or a patent processus vaginalis do not develop hernia. Shutter mechanism is also not true because repeated acts of crying does not increase the incidence of hernia in newborn babies in spite of the almost absent obliquity of the inguinal canal or shutter mechanism. Shutter mechanism at internal ring says medial border of the internal ring is pulled upwards and laterally to close the internal ring, and shutter mechanism at canal says that oblique fibers of the muscle arch moves down and medially to go close to the inguinal ligament. This opposite movement of the same muscle cannot be accepted. Those concepts that are said to prevent herniation are not at all restored in the today's techniques of inguinal hernia repair, and yet 70 to 98% of patients are cured. So these are not the real factors that prevent hernia formation. Then what are the real factors that prevent hernia formation? Our theory is aponeurotic extensions from the transversus abdominis aponeurotic arch in the posterior wall is the real factor. This is the picture of anaerobic inguinal canal posterior view. See, these are the aponeurotic extensions which are present, which covers the inguinal canal here. This is the cross section of the inguinal canal. See, these are the aponeurotic extensions from the transversus abdominis aponeurotic arch, going and getting inserted on the ileopubic tract. That gives real protection. This posterior wall is dynamic also. This posterior wall is kept physiologically dynamic due to those aponeurotic extensions and muscle contractions. Muscle contraction of the transversus abdominis pulls these aponeurotic extensions upward and laterally, converting it into a shield to prevent hernia formation. Physiologically dynamic action of the posterior wall. See this. This is the posterior wall which is relaxed at rest. But whenever there is action, transversus abdominal muscles contracts and this posterior wall is converted into a shield to give dynamic active protection. This tension in the posterior wall is created in gradation as per the force of contraction of the muscles, and the force of contraction of the muscles changes as per the force of the internal abdominal blow. This is important physiological phenomenon. The posterior wall plays an important role in the prevention of hernia formation not only because of its anatomical strength but also because of its physiologically dynamic nature. Such a physiologically dynamic and strong posterior wall is needed to be constructed to give 100% cure from the inguinal hernias. My operation technique gives such a dynamic and physiological and strong posterior wall. We need to change today's trends in groin hernia surgery because mesh repair is based on anatomical principle. Mesh is stitched to prepare a curtain. This curtain becomes the posterior wall. Such posterior wall is not physiologically dynamic. It is a simple rigid anatomical wall. And the principle is physiologically dynamic and elastic posterior wall gives better protection than a simple rigid anatomical wall. Protection in early period, anatomical versus physiological. Mesh repair gives anatomical wall at rest, whereas in action also it remains relaxed. Whereas in my repair, it is relaxed at rest but gets converted into a shield to give the dynamic protection. Protection in later period. Rigid wall, mesh gives rigid wall which moves up and down as a whole, so there is always a stretch on the suture line. So recurrences are always seen in the suture line. Whereas in my repair, the posterior wall is elastic and dynamic, so the pressure is distributed everywhere. Rigid versus elastic wall. Protection. Mesh repair, there is zero protection on the day one, and slowly and gradually this protection goes on increasing over a period of years. Whereas in my repair, protection starts from the day one itself. Status today. Today this operation is being followed in many countries all over the world. More than 100 presentations or publications and a dozen RCT are conducted on this repair. Results are similar to or superior to mesh repairs. Global data of 11,170 patients operated by different surgeons was presented in World Hernia Conference in 2015. It showed recurrence of 0.2% and complications of 1.8% only. Our data of 2,500 patients showed fast recovery, early ambulation, less than 0.1% complications and only one recurrence. Many textbooks like Love and Billy, Schwartz, etc. have included this operation technique. We are the first in the world. We are the first to put before the world that inguinal hernia must be repaired on physiological principle. We are the first to scrap century-old theories that prevent hernia formation and publish new theory. We are the first to give you a very simple hernia repair that does not use mesh or foreign body. We are the first to use all absorbable sutures inside, leaving no trace of foreign body after surgery. We are the first to give you almost complete cure after surgery without any fear of recurrence. Wikipedia was the first to describe it in a separate section as tension-free pure tissue repair. Now you decide whether to continue with open or laparoscopic mesh repair or to shift to this mesh-free Desarda repair. My answer is there is no place for mesh prosthesis now in hernia repairs because no mesh technique of Desarda repair is available with superior results. Now we present to you our live video of operation technique of mesh-free Desarda repair. You can watch this video on our popular website also, www.desarda.com/videos. Warning: Ethicon, Boston Scientific Corp and C.R. Bard are among 7 companies facing more than 70,000 mesh injury lawsuits in federal court and thousands of additional cases in the state courts of the USA. Here companies are playing safe by using doctor's card in the court litigations. Ethicon's lawyer said the product was thoroughly certified by the doctors and the doctors considered the mesh used to be the gold standard for treatment. Therefore, every surgeon should take an informed consent in writing from the patient to avoid the court litigation following mesh complications after mesh repair. Take consent that mesh is a foreign body. It is a piece of synthetic cloth prepared from polypropylene or polyester. It is associated with possible complications of recurrence, pain, infection, testicular damage, hematoma, seroma, migration, rejection, perforation, sinus formation, intestinal adhesions, sterility, etc. etc. Patient may file a suit against the doctor and the hospital if such informed consent in writing is not taken from the patient before hernia surgery with mesh. These are some of the photographs of my presentations in international conferences. Thank you very much.